everybody's getting signed in. So we're going to talk about one of my least favorite subjects tonight. But in order to keep up with our National Registry education and keep up with our Texas certification stuff, we have to talk about OBGYN from time to time and child delivery. Now, I'll precursor this. There is a few pictures. It may be a little, but she is a female, so perfectly if there was a younger boy in the room, we'd have to have a little discussion. But so we are going to talk a little bit. So let's start off by first of all saying who in the room has actually delivered a baby or been in the room when the baby was delivered by your partner? Okay, so a pretty good size number, but there's still several of you that never have. So how many's truly ever seen anybody crown? So this is the number one thing. Let's make that 2 cards now. That's how we're going to title this because that's what happens when that baby comes along. This will be 1 hour for state and 1 hour for obstetrics and pediatrics on National Registry and an hour for OB or medical for the state. Okay. Okay, so some of the things we want to talk about today is the physiological changes that happen when we get into leading up to labor. We want to understand the signs and symptoms of labor and impending delivery. Sometimes when we want to think about loading up, and sometimes we think about let's just stay and play because I really don't want to do this bouncing down a road. Follow the process through the fetal descent to the birth canal. We want to talk about considering interventions for the mother and the neonate. Also want to consider when a baby is viable. And what are we going to do with that baby if it's not viable? It becomes a very big issue for us, and we're going to talk a lot about that. And then actually look at some pregnancy reports. So, I told you there's some explicit pictures here. I didn't say nothing. Yeah, that was him. Okay. So sometimes when we're delivering these kids, this is what we think. This is what we're getting ready for, especially for those of you that have never delivered one. You're kind of going, man, this thing's going to come out, and you hope it's only got 10 fingers and 10 toes, and sometimes they come out and they got 12 of each. Or they may have both sex parts or something like that. So you got to start thinking about these things. But this, at the end of the day, is what we're going for. This is the actual of what we're dealing with. So let's talk about labor. Typically, labor should start about week 37 to 42 weeks in gestation. This is what we call our term babies. Okay, this is a full-term baby after 36 weeks by national standards. We start talking about the processes. This has been a natural process for many years. For many, many years, longer than we've been giving medicines. They didn't give medicines for birth. So these people can endure it without medications. If we give medications before that delivery, what are we sharing that medication with? That baby. And I may have a sedated baby or a baby that's opiate dependent at that point, or maybe respiratory distress because of something that I gave. So we need to be careful with that. We'll talk about that. This is a frightening experience for those of you. How many people have kids in the room? Those of you that haven't been in the room when a young lady's given birth, man, they change. She becomes a monster. I got yelled at during birth, and that's okay because she was going through something that I would have never made it through, and I'll say that very bluntly. When we talk about the complications that they can have during these deliveries, we need to recognize these complications quickly and get things taken care of. We want to provide appropriate neonatal and maternal care post-delivery. That's a very big thing that we get these situations taken care of. So, 2012, the new guidelines come out, and they actually talk about preterm is before 36 weeks. This accounts for 1 out of every 9 births in the United States of America right now. Now, third world countries, I bet you this number is probably significantly higher. We did not look at the CDC stuff on that, but I can tell you in the United States of America, 1 out of every 9 is going to be considered a premature birth. So in saying that, how many babies are born at UMC a month? Any guesses?
3,000.
A month? I'm 650. I can assume they say about 100 babies a month or so, okay? And UMC claims they have about 54% of the market share of OB delivery. So 200 times a month, there's 30 days in a month. You do the math, what the chances you have an OB in a month? It's pretty high. So this becomes a big part of our business from time to time. So some of the things that consider preterm birth, alcohol and substance abuse, smoking during the pregnancy, this is a big one. Twins, triplets, and even more kids. I can honestly say I've never been on a birth with more than 2, thank goodness. But I'm sure there's somebody in the room. Got any 3 triples in the room? Oh my gosh. Oh Lord. So you had 3 at a time? Wow. Gee. Do you know what car insurance is going to be like? All at one time. Okay. As a part of that. Maternal age becomes very important. Very young and very old when we need to start really suspecting premature birth. Or maternal medical conditions such as infections, hypertension, being malnutrition. Guys, we've had 3 instances in the last 3 weeks where the mom after delivery said, I didn't know I was pregnant. Okay, so that becomes a whole factor in itself because you know she's malnutrition through that. She didn't get the supplements she needed, and she probably wasn't eating right the whole time. So let's begin the labor process. Let's talk about, so we can get a big change in hormones. We start getting dump of estrogen toward that 30s, or actually about that 3rd trimester. This is where we start to thin the cervix and our effacement starts to change. And I'm going to show you some pictures of that so we know everybody knows exactly what we're talking about. This can be just an uncomfortable beginning. Okay, this is where we get some Braxton Hicks. This is where we get some of that. You know, guys, I can't imagine, especially in August, you know, you're this big, everything's pushing, you can't breathe, it's hot, you're miserable. That's part of that process. But as we continue to dump enzymes, these break down the collagen fibers in the cervix and allow things to start stretching and moving how we need to. We also get a dump of CRH hormone, and I'm going to leave it at that. This is a normal hormone that even is there without being pregnant, but this starts to affect our hypothalamus and our neurotransmitters and things that are going on. As this portion goes along, it still continues to trigger different things of how far we're going to go into this delivery process, and we're going to push through these things. This is what starts to trigger labor. So why are hormones important to us, right? Because I don't draw hormone levels in the back of my truck. I don't have a lab value that tells me these things. But it's what does affect sometimes these hormones are affected by delayed deliveries because of drugs they may be taking. NSAIDs. What are NSAIDs? Aspirin. Okay, what else? Huh? Toradol. Ibuprofen. Are those drugs we have on our truck? You bet. Are those drugs that we could theoretically give to a pregnant female? You bet. So that could start affecting these dumps in hormones. How many patients are on calcium channel blockers? If they're hypertensive through their pregnancy, the doctor may have them on calcium channel blockers. That's going to be a delay in delivery. These medications are going to prolong that process. Beta antagonist drugs. These drugs are used a lot of times for high-risk patients. So if they tell you I'm a high-risk patient, I'm on calcium, I'm not saying every time, but you can pretty much guarantee they're going to have a delayed process. So if they tell me, okay, I think I'm having this baby, well, honey, if I don't see it crowning at this time, then I bet I'm going to be a little bit more delayed. So I can be a little bit more relaxed in my assessment and how rapidly I'm dealing with her. But that doesn't mean that they're going to be delayed. Please do not attempt to, I know, why do we say this is because some paramedics probably try to do it. Don't give drugs in order to try to delay their delivery. That is not our job in the field as paramedics, okay? Why do we say things? Somewhere somebody did something that caused us to have to say that. So do we drag out the OB kit or not? Yeah, this right here doesn't work, okay? Please just hold this aspirin right between your knees, okay, till we get to the hospital. That does not work with the crowning female. And saying that, I got a 39-year-old female or 39 gestation week baby who's complaining of belly pain with contractions. When's it time to break out the kit? Well, I need to start thinking about things. Is this my first delivery or is this multiple deliveries? Is this baby 10 or is this baby 1? Everybody knows, and if you taught this in medical school, that baby number 1 is going to be typically a longer delivery process than baby 10 is going to be. We also talking about something called lightning, and this is where the fetus starts to move downward into the canal. This is getting into what stage do I need to be in. This is where we're moving through the pelvic inlet, and we start to get everything ready. This is where we start to get pain, cramps. They're going to get some very uncomfortable pressure in the pelvis. but they're still not using that magic word of I need to go to the bathroom. At that time also, you're going to get a little relief in respiratory, so they may think, oh, wow, man, I was having this battle, and that feels so much better. That last contraction, I can breathe a lot easier. What does that tell you? That baby is starting to line, he's starting to move on down to that pelvic ring, and so I may be starting to remember, okay, now I need to start moving forward with my process. I may be time to get my airway back out. Then we start talking about a bloody show. This is where our mucus plug is released from the cervix. This is where I may get some discharge. Typically, this is the start of that. They'll typically deliver within about 48 hours post once that mucus plug gets broke. Increase in back pain. Well, everything's moving, the joints, everything's starting to settle in. You have a sudden burst of energy. So if they say, you know, I've been up and they're what we call nesting, and you know, my wife is really, really bad about this. She was up cleaning everything, and I was like, babe, I don't think you should be doing that. Next thing I know, it's time to have a kid. So that could be one of those signs of thinking, okay, we've been nesting for 2 days, and now I've got this, all of a sudden I'm breathing better. I may need to get my OB kit out. Rupture of the membranes of the classic I broke my water. This is where the amniotic fluid has ruptured at that point. 80% of the females that experience this are usually within labor within 24 hours. So if they tell you, hey, 48 hours ago I had a big gush of water, well, what are you doing at home? Okay, you should have been at the hospital. Well, no, I was going to wait and call y'all and take you at the last minute. Something to consider, though, guys. After 24 hours, we start setting up. Once we have rupture of the amniotic fluid, we really start to run a high risk of infection. So if they're staying at home post, 48 hours, I really need to start thinking about that fever, start thinking about high blood pressure, start thinking about that increased heart rate, and signs and symptoms of I may have a bigger, badder problem. Because if I'm going to do a dirty delivery in the field with a baby that's coming through an infected area, what's my problems? You're going to have some, okay, I promise. You're going to have to get ready for that. Also, another thing is once the amniotic sac ruptures, this is where we start higher risk the longer we go of having a prolapsed cord. So it's something that, guys, I know it's not our favorite thing, but I'm going to have to take a look, okay? I'm going to have to be professional about it. I'm going to have to get the pants off. I'm going to have to take a look and make sure that I've got crowning and I'm not seeing a foot or I'm not seeing a butt or I'm not seeing a cord sticking out first. And so I need to make sure I'm getting ready. So we get even closer to delivery and they're able to tolerate these contractions and the timing becomes more regular. Oftentimes these are ranging 3 to 30 minutes and they may only last 20 to 40 seconds. This is where the cervix begins to start to dilate. Your effacement starts to thin. They're going to give you a number. It's a very important thing to ask. When was the last time you were checked, and what were you at? And they may say, you know, I was checked 48 hours ago, and I was at a 1, and I was 5% effaced. What does that tell you? I probably got some time. Because I'm not that much. Now, if they tell you I'm 100% effaced, I'm dilated to a 10, and I've got pressure, what do you need to do? It's time to get ready to catch, okay? So get your kit out and get ready. In the later phases, this is about 8 hours. This is where we start, typically once they start this process to having these constant, more regular contractions. This is where within typically on our first deliveries, about 8 hours is the window we're looking at. On some of our multi-gravida patients, about 5.3 hours is the national average of where these folks are averaging. So if they tell you, look, I've been real constant, you know, this is baby number 5, and I'm real constant for about the last 2 hours, you may not have a lot of time at that point. You probably need to start getting things a little bit more moving forward. So we talk about the beginning of the labor. This is where we start to talk about our effacement and our thinning and what we're dilated to. Typically, this opening, they use fingertips, and I'll have to tell you, I'm not real educated with this process because it's something that I've never done. You talk to some of the nurses in the room or the doc in the room, and you know they're very educated in this because they have to do this. The thing is, once the amniotic sac is broken, this needs to be a sterile procedure, and that's why we don't do this in the field. Is because technically, once we've had the breaking of the water, that really needs to be a sterile procedure at that point. So the canal itself typically is less than 1 centimeter open at this time. This is where we start to get our effacement of how much The cervix is thick at this time as we start to thin. Now, the wording here, as we start to thin, this is going to actually retract. This is where we get our dilation, and this is where we get our thickness or our effacement. As we get in here, and the man's over here, and he says, I can relate to your pain. That cold last week was miserable. You know, and you've seen the husband and the wife over there going, she's growling at him at this point, and they're upset. But as this progresses, these become more intense. And for those of you that haven't been on a delivery, this is a big thing. Because you've got to be a coach at this point. You may not always have the husband there to, you know, we went to breathing class together. I'm going to breathe with you, honey, okay? We're going to, okay? You may have to be that coach while I'm also the deliverer. So I'll be down there doing the thing. She's going to be the deliveree, and you're going to be the deliverer. But you may also have to be that coach. This is where our contractions become very regular, about every 1.5 minutes to 2 minutes, and can last anywhere between 60 and 90 seconds long. Sometimes it can be brief. Now, in the hospital, what are they monitoring during this time? Fetal heart rate. Okay, that's something we don't have. We don't have total monitors in the field. They don't have a good one in the field that they can use. Is what they're seeing here is, where's the cord? So if you have a decel or you have an acceleration, if that baby's stressing one way or the other, they can pretty much tell where that cord is and where it's sitting. We don't have that ability in the field. The only thing we know is it's time for us to start getting ready for this because we're getting stronger and stronger. Then it becomes to the urge to push. And this is where you know, the fetal head starts to apply pressure to the sacral as we start to get down through the pelvic ring, through the cervix. At this point, this is really getting into the big time. We're fully dilated. We're to a 10. This is where we're talking about our effacement, and our dilation is right here. Our effacement is thin. She right there is probably at about a 9 and probably 90% effaced at that point. Is that pretty fair, nurses? Doctor? Probably pretty close. They're starting to really thin out. Sometimes it may not take long to finish at this point and go all the way to a 10 and start that delivery process. So what do we need to start doing? And we're going to stop right there for just a second, and we're going to talk a little bit more because this becomes a very important part. Cardiac monitor. We need to kind of play in a tug of war because the parasympathetic, the sympathetic nervous system had kicked in. We have endorphins dumping. We have hormones going. We've already talked about that. Catecholamines going. These are also affecting the vagus nerve because we're pushing, we're doing things. I need to have them on the monitor. I need to know what's going on. Now, I had a very interesting call a few years ago. We actually talked about it in case review. I happened to have a lady, I was picking up a shift in Slayton, and it was very important I had her on the monitor because we're trying to deliver. I'm coming in. We're going code 3. I don't remember who my partner was. We were driving real fast. I called Troutman on the radio, and I said, hey, we're having PVCs, and we're in Bi-Gemini. And he's like, roller to her side. Do you remember this call?
Yeah, very. That was a
long time ago. You were a rookie pretty much in the ER at that point. Well, for here. Yeah. And so we rolled her to her side, trying to get the pressure off. I'm thinking, well, she's just a little, you know, oxygen dependent. Put her on some oxygen. We're hauling butt. And the more I look at this monitor, the more sick I got because there wasn't nothing I could do with it. And so Troutman gave in very wise words. He said, add diesel. And so that's what we did. We added more diesel. We made it here. And the OBGYN doc goes, what rhythm's that? What are those things? And I was like, oh, we're in the bad spot. But anyway, we went over to OB. So you can start expecting delivery soon, guys. Once these things start, you're getting very close on your contractions. You may see things. You may see PVCs. You may see you could possibly even see some runs of VTAC if they get really irritated. They're really bearing down hard. You may see those things. You may see that lack of oxygen being provided to the myocardial, and that's what you're starting to look at. So heart monitor is very important. I also need to have IV access. This should be ready for pain medication. Post-delivery, we can take care of their pain. Okay? We can take care of their pain post-delivery. They need to have a fluid route. I need to go ahead and have all that set up because what's going to happen once I have the baby and the mama? I don't have time to go start an IV on mama while we're going to the hospital now because I've got baby too. External examination. You know, these are things, guys, when we're documenting these things, when she says, I have a contraction, put your hand on her tummy. You'll feel it get really hard. Versus she says, oh, I'm having a bad contraction, but her tummy's still soft. Okay, that tells you that it may be coming from the backside. It could tell you a lot of different things, but document that. Okay, I'm starting to have the firming of the stomach. You need to check that at the beginning, check that at the end, because you're going to be able to feel those things. Do a full assessment on them. Do I have 4+ edema in the ankles? What does that tell me? Okay, it could tell me, well, that's just the normal process of delivery, or it could tell me I may be having a lot of fluid on board, they're hypertensive, it could be a lot of things for us. So they need a full exam. Maintain their privacy. Guys, if you're in their residence, keep them covered up as best you can. Try to do the best you can. A vaginal exam. This is not a procedure that we do in the field. So we've already talked about that. This is something that we have to be careful with because of the fact of infection. This is a sterile procedure done in a hospital, and I need to make sure that my hands are not in there unless I have to create an airway for a baby on a breech delivery. Okay? That's the only time that's approved in the field is to put your hands in, and that's going to be on a breech delivery. We'll talk more about that.
Or also if you have a prolapsed cord, where you reach in and raise the baby's head off the cord. Those are really the only two ways. It's even rare. Occasionally we'll do this exam in the ER, which we're fortunate here we have OB. The patient generally goes straight to if we're not sure, but yes, we use a sterile glove because kind of like you touched on, the concern is if it's a non-sterile glove, there's bacteria on there. You introduce that. Well, if that woman lays in labor 10 hours and there's some fluid, even though maybe their fluid is broke, there's still some fluid around, and then the baby ends up aspirating whatever was on the glove hanging on the wall or in the back of the truck. So they're going to end up with a pneumonia, potentially. That's why we don't do that.
You need to be careful with that. So now we get to crowning and presentation. Guys, this is where it starts getting real for us, real quick. I need to make sure that I've got my OB kit out at this point. Delivery is imminent at this point. There's no use, in my opinion, to try to go to the truck and try to do this bouncing down the road. It's going to make things, you're going to have the same result. Okay? If you've already got crowning present, you're there, that's a judgment call on your part. Okay? For Chad, I like to stay in that house where it's stable, where it's a fairly clean environment. Maybe move to the truck and do it in the truck, but still not bouncing down the road. Okay? That's totally a judgment call on your part. Now, if you're the type that says, I got to get that aspirin between, let's haul butt, that's going to be up to you. I'm comfortable delivering a baby in the field. For your first time, it may be, let's go. Let's add that diesel and let's get to the hospital. Do you have a viewpoint?
If you're truly crowning, you're not going to prevent that baby from coming out, first of all. And probably it's coming out in the next, again, if it's truly crowning, heads about your 5 to 10 minutes, that baby's coming out. You're not going to keep it out.
Good luck.
Yeah.
That's a judgment call, something that you have to do. But guys, things we do want to do. We want to drape a clean sheet or blanket underneath the mom. Okay. There is times that there is a lot of fecal associated with the delivery. That's something we don't want to get our kid into, our fresh baby. Okay. So I want to make sure they have something down there where I can wipe and clean and kind of keep my barrier clean up top. Delivery is a messy process. There's no two ways about it. It is going to be, if you can get a gown on, get a gown on. If you're comfortable wearing glasses or whatever you get your hands on, you just don't ever know. So get donned and doffed and get ready to go. Get eye protection in place. It's the one after this is going to be the big one. Okay, so the process, so as we move down, this is the descent through the canal. Right here we're starting to introduce, we start to have a little bit of rotation on the baby's part because it's trying to fit through the pelvic ring. At this time we have an extension through and then external rotation, and I've got some really good pictures of this coming up. So this is actual pictures of the crowning of the baby. This is actually what you're going to initially see on crowning. As you start to really get a good crowning coming out, this is where I've got to use the hands to start to support the baby's head. I get basically full presentation of the head right through here. This is where I've really got to support. This is the best time for you to suction. They have not taken a breath yet. You do not have expansion of the lungs at this point. If you can get down and suction nose, mouth, get it cleaned out as best you can at this point, it's going to be in between contractions. Okay, you may have a minute, minute and a half to get this done. This kind of is a process. This is, for me, the longest time because you're sitting there working, and at the same time, you're not able to do a lot because you're just kind of waiting. But sometimes this process may be. And then you're going to have external, you're going to have the rotation of the head. This is where the baby's shoulder's trying to get through. It's going to try to drop down, and that's when the baby's going to actually rotate some. So if you've never seen this, I know this is a little vulgar, but at the same time, if you've never seen this, it's something you need to see. This is something you need to know of what stages it's at, and I need to be real cautious about supporting that head. Okay. So we talked about, now we get the kiddo out. Okay. Remember that kiddo is going to be very slippery, very wet. I need to be very aggressive with drying that baby. Once I bring that baby out, I need to keep the baby as level as possible to the mom's bottom. Okay? So I need to keep things just as level as possible. If I raise the baby up, I can actually drain the baby somewhat of blood. Think of it that way. So if I've got a pitcher up of water here and I got a tube between them, it's going to run down. That's exactly what happens. And now I've got a hypovolemic baby that I caused. At the same time, if for some reason we're on a bed and now I squat down on the floor to take care of the baby and I bring the baby down, same process. Mom's going to continue blood flow through the placenta, through the cord, and can actually give a lot of blood to the baby. Is this a big factor for us? Hopefully not, because we're going to be moving quickly to clamp that cord. At this point, I want to make sure that I clamp my cord about 4 inches from the baby's abdominal area. At that point, I want to make sure I pinch and then I squeeze. I milk it. You've got to get the blood out of there and then clamp on the other side. If you clamp that with high pressure in the middle and you go to cut, do it again, Brian. That's what it is. You're going to be wearing it, okay? And then you got a high risk of getting stuff in your eyes and your face, and we don't want that, okay? So we need to make sure we milk that and get it clean. You may have some moms that say, I want Dad to cut the cord, okay? That's your judgment call. If that baby's stable and doing well, that's fine. That's a very special moment in a dad's life that he may only get once. So that's totally going to be a judgment call on your part, depending on how stable that baby is. We're going to talk about that stableness, though, here in just a minute. Remember, I need to get an APGAR score. These APGAR scores need to be done at minute 1 and minute 5 per national standards. This APGAR score is built into your protocols. I understand that at the time of delivery, you should have a general concept of what this number should be, but may not hit the nail on the head till I get back to the station and I'm documenting it. I have a respect for that because I know you're trying to remember all these different numbers to add up. But what we're talking about is activity. We're talking about what is the muscle tone. Are they active? Are they moving? Do they have flexed? Are they absent? Or are they a flaccid baby? Pulses. Is the heart rate greater than 100? Below 100? Are they absent? Grimace. Sneezes, coughs, pulls away. Or are they grimacing? Or is there no response? Appearance. Normal or normal over the entire body. Normal except the extremities. Or are they cyanotic and pale all over? That's going to be a big factor for us. But something that it's normal to have a lower APGAR score at the very beginning, then 5 minutes later we'll talk about that more and why. Respirations, is it good? Do they have a cry? Are they slow and irregular, or are they completely absent? So it's something we've got to kind of think about how we're going to deal with this. Remember one big thing. We've got to dry and warm these babies aggressively. We've got to get them covered up. Ambient air can kill your kid. So if you're in the back of the truck and people are walking by, or you've got a door open or a window open, the front cab window's open, you've got a breeze coming through, that baby's wet, that's ambient air, okay? That can cool your baby rapidly. Babies, neonates, do not have the ability to shiver, okay? They have very limited brown fat. What carries our brown fat when we're first born? Sugar, okay? The more sugar we got to burn, the worse off that baby's going to be. So they don't have the ability to shiver, so I've got to keep them warm. Let's talk about oxygen a little bit. I know as a medic, if I put a pulse ox and I see 60 on a 1 minute old baby, I'm kind of freaking out. I'm not going to lie to you. I've been doing this a long time, and I've seen a lot of little babies, but I'm not going to lie to you. It freaks me out to see them that way because that's not normal for us. But it actually is. The first minutes of birth, typically 60 to 65 is normal. Minute 2, 65 to 70. You can see as the minutes go by, it may take up to about 10 minutes to get up to about 85 to 95. Every baby is born with a ducti. Every baby's born with a hole. That's part of the process. Sometimes it takes time to close those. Sometimes these baby stats may stay low for a little bit. If you have to consider oxygen, be very cautious This should be for central cyanosis, low heart rate, poor respiratory effort. Avoid blow-by. Okay, remember, oxygen can damage those babies' eyes. Another thing is, what does that blow-by do if that baby's wet and I've got it held down here on the chest? That's ambient air. Okay, I'm cooling that baby at that point. So I've got to be very cautious with how I deliver that. I may want to use a BVM, a neonate BVM, and be able to make pretty much a seal. Not a whole seal, but able to just squeeze and give air straight into the face, into the mouth.
Just one comment. Remember, like the 60 to 65% as far as their oxygen, that's what we're going to see on the pulse ox. In reality, if you could go into the heart and take a blood sample, their oxygenation is going to be closer to 100. With the patent foraminal-valley and the ductus in utero, that blood stays very centralized. When a baby comes out, what color is it? Kind of a gray, bluish, because they don't have just a lot of peripheral circulation. That's just how Mother Nature intended, I guess. But then once they come out, take those few breaths, technically the foraminal valley closes, the ductus take a little bit longer to close. Then as that happens, the way the blood's shunted, the pressures change, and that's why the baby pinks up. So it's not really that the baby has a 60% O2 sats, that's just what we're getting at the finger. Does that make sense?
Questions? Okay.
I have one question.
Yes, sir.
What if we get like a presentation of a normal baby, but we've got these broad shoulders and they can't get it through where you usually use an episiotomy? What do we do with that?
Diesel.
Yeah, I mean, those are difficult. When we just think about deliveries in general, probably 90% plus of deliveries are very normal. It's kind of like what we do in emergency medicine. Probably, 98% of what we do, probably most doctors could probably do fine. We're emergency medicine specialists for that 2%. Anesthesiology, I probably could go to the OR and deal with somebody and put them to sleep with what little bit I know about anesthesia. But there's that 2% that's a big problem, right? OB-GYN, same thing. Babies have been born for how long? But those OB-GYN experts are for those broad shoulders and babies that are not doing well in utero and they need C-sections and stuff. So, a few things. The APGAR scores, those are very important. They're not really important for us, but they're really important for those people we're handing off to know. And I couldn't stand here and tell you about all those details, but as far as the NICU, the pediatricians, it really kind of predicts future outcomes or expectations of that baby. So it is very important to try to get those accurate numbers. I don't think anybody here needs to memorize that APGAR score or the table. Just know, like, oh crap, I need to go get that APGAR, pull that table out. The stuff's in there, stuff that you're doing already. So just you can refresh your memory and, okay, here was my score, and hand that off. So remember, as the patient is crowning, or maybe it's even a little earlier than that, and you're transporting, avoid PO medications. We know why. In case they have to go to the OR, right? Remember, not every baby is going to come out vaginally. It may need to end up being a C-section. If it's an emergent type C-section, it's not going to matter if they just left Golden Corral and ate a buffet. They're still going to probably have it done, but your complications are higher. Potentially whenever you have had something PO. Morphine is safe with pregnancy. We don't have that, not in review in the protocol, we don't say we can't give it, right?
Right.
So, I mean, it's safe to give in pregnancy. Just remember that certainly, and probably if you give it and you end up doing a delivery in the next 10-15 minutes, I don't think it's probably going to have an effect on the fetus that quickly. But it can. So again, what's morphine do if we give enough of it to all of us? Suppress your breathing and what have you. So it can do that same identical thing to baby. So breech delivery or any kind of complicated delivery, we kind of get the shoulder dystocia, and there's all these, and not just the reach, is it the McRoberts maneuver, the corkscrew? There's all these maneuvers that are way beyond what we do. That's something for the OB-GYN. But when we have those, we need to get onto the hospital, and we don't want to encourage delivery. Again, there's nothing we can prevent. If there's a foot, we don't, oh crap, let me put my hand over and hold that foot in. The uterus is going to contract. Mom instinctively somewhat's probably going to continue to push a little bit, and it's just, you got to go and see what happens. You know, breech deliveries happen. They sometimes even OB will electively do a breech delivery. You know, especially, you know, they'll look at pelvic sizes and how many babies moms have with their breech. They may try to actually do a breech delivery. So it's not unheard of. Just because they're breech doesn't mean they may not come out. Somebody mentioned the big shoulders. Again, yeah, ideally there's those maneuvers. Sometimes the OB may take a knife and make a cut, episiotomy, but also sounds bad, but also at some point mom may rip a little bit and baby come on out, and that's not necessarily a bad thing. I mean, that happens. A trauma in the birth canal is not just completely abnormal. So I think that's good. The next slide, I think that was all put on that one. Yeah, so, you know, delivery is something we do. It's just kind of part of the job. And fortunately, like I said, 90+% of those are births that we probably could do at home, just like people have done for hundreds or thousands of years. All right, I'll let you continue. Do y'all have any questions for me on that part?
Okay, so the viability questions come up. A couple of y'all in the room, we've had some unique calls over the last month or so, I guess you could say. And so a lot of questions have been brought up. What do we do with these non-viable babies? So by definition, we'll just define it first. Sadly, this is part of our job from time to time. These are hard calls. Not an easy call for anybody. And if anybody tells you that it's not, they're lying to you, I promise. But typically, in our country, 24 to 25 week gestation is what they consider a viable baby. Okay? So is that saying if I deliver, she tells me she's 23 weeks, that I'm not going to work it because that's not viable? No. That's a judgment call on your behalf. This is something I can't teach you. This is something I can't say. This is this time, and this is this time, and this is this time. It just doesn't work that way. It's got to be a judgment call on your behalf. But by standards, 24 to 25 weeks is the range for viability in the United States of America. Even saying that, the literature says that's about a 50% expected to live at that point. Now, in saying that, so people are going to ask you, well, how long, you know, I delivered this little baby, how long am I going to be in the neonatal unit? Typically, what they tell you is plan on being there until your due date, okay, until the baby's ready, okay? And so the baby would normally be ready on this day, then you kind of plan on being there. A number of factors come into play here. Socioeconomical statuses, maternal nutrition, gestational age of the baby, a lot of different things come into play here of if these babies make it or not at 24 to 25 weeks. So if the fetal age and appearance suggest that resuscitation will be futile, we need to call signal 28. Okay? We need to notify the comm center that we do have two patients. You do. You have two patients. I have to claim that other patient, and I have to call that baby deceased at that point, if you make that decision. If you work that baby, it'd be no different. You're going to do another full report for it. Okay? You're not held at liability for calling or versus not calling. Like I said, that's a decision point that you have to make on scene. Some of the older medics in the room are probably going to be a little bit more comfortable with calling one of these that's maybe 20 weeks gestation or 22 weeks gestation versus those younger kids in the room. Nothing wrong with that. It's part of that. Education is part of things we've seen through our careers. There may be a time that just maybe say, typically, well, this one I think we just probably need to go with it, so we're going to work it. So when in doubt, resuscitate. That's what we're saying at the end of the day. Just remember that you do have two patients. You do still have a mother to take care of. What's your priority there? It's got to be up to you. You're going to have to split up as a team, and one of you take the baby, one of you take the mom until more help comes. If you're delivering, if you know you're going to be delivering this baby and you're talking about 23, 24 weeks, you may want to go ahead and get another truck coming your direction, okay? It's easier for us to turn them around than it is not having to wait 8 extra minutes for it, or whatever it may be where they're coming from. Not to transport it to transport. This question got brought up. Okay? We had a call that I chose to call the baby at the scene and chose to leave the baby at the scene. It had a lot of different factors in it. I had a really neat experience talking to the crew afterwards, and they shared some of their points of it with me. It was my call. I decided to do that. Looking back, would I have changed it? Probably not. But I did get to see a different side, and I got educated some on it. So it worked out very good for both of us. We talked to the medical examiner's office. What's y'all's view? They said it's got to be up to your decision. If your mom has ties with that baby, okay, my situation is that the mom she didn't even know she was pregnant. She had no ties to that kid. She had to ask what that was. Therefore, it made it a little bit easier for me to separate at that point. But if mom has ties to that baby and she's carried that baby, she may need to take that baby to the hospital. That's appropriate. Okay? Wrap it up in an appropriate manner. Take care of it. She may want to hold it. That's fine. You can do that. Meet her needs. The ME's office is not torn either which way. They want us to do what that mother needs us to do. They want us to do what you need yourself to do. Okay? I can't sit there and say, you got to do this every time, because that's not the right thing. Sometimes it may say, I need to take that baby to the hospital for my good sake. I may need to work that particular baby for my sake. Okay? It's something that you got to make that decision for. Otherwise, if we're going to transport the baby, but I still need to call that baby signal 28 if I'm not going to work it. Period. Has to be called signal 28, and that report has to be documented. Okay? Wrap it up, transport, give the ER, when you're calling ready to report to L&D, whatever may do it, tell them, I have 2 patients. One of them, I have called signal 28, baby is not viable, we're choosing to transport. That is totally up to your decision, but you need to notify the hospital that you're doing that. So let's talk about some case studies. 20-year-old female from the jail. She was pregnant. Her water broke. So what does that tell you time frame wise? 48, typically within 48 hours, but I know within 24 I may have possibility of infection. Approximately 30 minutes prior to our arrival, so I know I'm in a good window here. Okay. Approximately our contractions are 1 minute apart. What does that tell you? I'm probably getting ready. I need to probably get my OB kit out. She has very stable vital signs. Little hypertensive on the diastolic side, but well, we're delivering a kid. Okay. Checked the glucose, did a great job. It's telling you her pain's a 10. It hurts real bad. But I want to look at something. What do you see right here? Uniform PVCs at 6 per minute. Uncommon occurrence? Not necessarily. Okay. Mom's oxygen deprived at this point somewhat, because and some of them just may have that irritation in the heart. But I just want you to understand, there's nothing you can do with this. So I have to give them oxygen, try to get them on their left side as much as possible. You can deliver a little bit on that left recumbent. Okay, it's not exactly easy. Kind of got to get creative with legs and feet, but you kind of got to be able to do that from time to time. Okay. They got an IV on her. Did a great job documenting of everything. They did the heart monitor. Then they even talked about they started to get PVCs. We had oxygen on board. They did a great job saying, hey, I even changed it when I saw those PVCs. I gave more oxygen. Okay, those are important points to notice. Okay, I wasn't getting what I needed here, so I moved up a little bit. As we find out, this is a separate call.
This is a different call.
Different call, sorry. 22-week gestation with twins. What does that tell you? You need 3 trucks. That's what that tells you at the end of the day. This call, they just left the L&D at one of the local hospitals 30 minutes prior, and they said that one of the baby's amniotic sac was already ruptured. So that's already kind of a concern for us. We have a multiple. The family was very concerned about her release. The crew did an incredible job here documenting. The baby was already delivered. One of the babies was already delivered on arrival. They placed the baby in the towel. The baby was not viable. The crew chose not to work this baby. The baby was ended up, and I'm not going to go into great detail, but the child was misformed a little bit. They knew they were a 22-week gestation, so they made the call not to work it. But at the same time, they did not notify the comm center that they had 2 patients now. Okay, so when I got ready to pull this stuff for the ME's office, it was an absolute disaster for us. It was very hard. to pull those papers and sort what's what. So you've got to be clear and claim that. This baby was about less than a pound. Kim, what am I missing?
Umbilical cord is
Okay. The umbilical cord was
dry and gray.
dry and gray. Okay. Those should be, they may be a little gray, but they may be pretty blue. They should be nice and plump. And they should be moist. Okay. This is very dried out, very rugged. What does that tell you? Part of that demise was way early on. Okay. So it's things you just got to kind of pick up on.
This is a different one.
Okay, this is a call, and this was actually a 29-1 call. This was a 19-year-old female. The EMT that took this did an absolute incredible job documenting, very, very thorough, occurring every 2 to 3 minutes. At one point, but this was from contractions since yesterday, and then it kind of stopped. We're 27 weeks gestation, and went through and advised that she had some fluid, and it was a very foul odor. Okay, so what does that tell you? That could have some infection. Did a very nice job being very, very thorough with all the documentation through this. Broke it down into everything, even documented that they noted no fluid drop, no fluid loss at that time. Very good job. Even described, hey, I did the blood pressure manually, and the patient was in the semi-Fowler's position on the stretcher. We did another manual pressure in the left lateral position. That's important for us to talk about of where we're at in the positions of when we're doing vital signs. And for that, we don't always award report of the month to paramedics. EMTs do a great job documenting sometimes, and Miss Teresa got a gift card to the Longhorn Steakhouse on the training staff. Oh, there's that. You may need that in case they don't do it right. But there you go, enjoy dinner on us. So very nice job with documentation this month. Very good job. So that goes to show you that's not all an ALS thing. Sometimes we go back to the basics to cover what we need to cover. She did a great job with that. Next we have this patient's in her 30s. She's in her residence. Stated she needed to go have a BM and bear down, and delivered a baby into the commode. This is not a too uncommon of occurrence for us that we find. Then she chose to put her pants back on, and she called 911. This call, the mom was found in the kitchen. Now, we're going to kind of break this up into two parts, but the mom was actually found in the kitchen here, and she had active bleeding noted, quite a bit of bleeding, as a matter of fact. The patient, the crew did a great job calming her down, getting her comfortable. We kind of split up into two groups on this call, and the mom was taken well care of. This is on the baby side, so this is what the Fox truck found. Was a newborn that was in the commode and was pulsus anatomic. It was shown to be a term baby at this time, approximately somewhere in the neighborhood of about 38 weeks. But in saying that, the cord, we noted skin sloughing. The crew noted skin sloughing off the shoulder. The head was noted to be somewhat deformed also, and this was a term baby, keep in mind. But we also noted the placenta being already delivered. What's the time frame? What process does a mom have to go through to deliver placenta in a normal situation? They start the delivery process all over again. They start the contractions, they start the cramping. Now, you'll see some of the OBGY docs, they'll give a little tug, a little yank, and they'll go ahead and remove. But for the most part, they're going to have natural delivery again of the placenta. So this tells me that this was a long time frame, but it actually wasn't. She had an abruption. She had a full tear of the placenta and had a violent delivery of everything. The placenta was very dark. It was not in good shape. The cord was not in good shape, and the decision was made to terminate this baby, terminate the call on scene. Okay? We bring this up because this is one of these hard situations. This is the call that I got to go talk to the crew on. This is the call that I got to go back and say, hey, what do you think about this? And we got to have a good conversation about it. There's not a right and a wrong. It's hard to make a decision to terminate a full-term baby. So it was a hard decision, but we saw the things, we added it up, And once again, I'll take it, but it was my decision for that. It was something we got to talk to the crew about. But that, just to show that it takes two cards at this time with full documentation of what's going on with both of those.
All right, so, this question came up on a few of these calls, and it kind of comes up on, okay, at what point do we work versus not work, fetus? Obviously, when it's 12 weeks, we don't work that, right? When it's maybe 28 or 30 weeks, we certainly really strongly consider working that, right? Especially if it's a baby that looks like it just came out. So there's not a perfect answer. I can't stand here and give you an answer. I think I kind of made that bullet point. Or your medical professionals, that's your opportunity to make a judgment call and then justify it with your documentation as to why you made that judgment call. Like in that case, we mentioned those important details of, yes, this looked like probably a viable size. What size did we think?
6.5.
6.5 pounds. Right, so I've got a son that was 4 pounds, so obviously 6.5 pounds, that's a very near-term fetus. But when we start looking at skin sloughing and all these other things, as we add that up, it's almost like going on the elderly person that's rigor with morbidity, right? The same type thing. So it's all about putting your justification down. We've kind of thrown around some various numbers. I think you were saying 24, 25. But for the most part, 24 weeks. And at this point, hours can even really change what the outcomes are. But pretty much that 24-week, if the fetus is less than that, the chance of survival right now is essentially zero. Will that improve in the future? Probably. If we were 20 years ago, that number was probably 26 or 28 weeks. Nowadays, a 26, 28-week fetus has well into a 90% chance of a normal survival. So I kind of put that 22 to 24 because, again, a lot of time patients aren't too sure. Well, I think my period was then, and try to figure it out real soon, or I haven't seen my OB or what have you. So that's where then it becomes very difficult. We don't run on the people that say, yeah, here was my period, and I've been to the OB doctor for every 2 weeks, and I am exactly 24 weeks and 3 days today. That happens every time, right? Right. So if in doubt, transport the fetus. But remember, if the fetus is not breathing, if they are not alive, and and you're thinking of transporting kind of for the purpose of, I think I have another patient here, we need to work that patient, right? When you make the decision to kind of transport that patient, you're transporting a patient, not I hate to use that word, but I mean, essentially it's a deceased body. So we don't transport deceased bodies, right? Whether they're 90 or 90 seconds old. So we want to remember that, too. Next slide. I don't think I have another slide. Cool. Do you have any other particular questions about this? Yes.
I have one on the writing the signal 28, which I think is fine, but at what point do you not write a signal 28? I mean, we run on 20-weekers or 17-weekers.
From a legal standpoint, from the ME's office, if it is outside of the body and it looks like a human, it needs a report.
Okay, and that's something I wanted to kind of get
That's
clarified
what
for everyone.
the ME's office has asked. Now, at the end of the day,
I mean, I would probably agree. I don't, or do y'all have any other opinions on that? I mean, those 12 weeks, you really don't see much, kind of crumpled blood. But, that 16, 18 weeks, you kind of see something there. So those cases, we probably should.
It's what her words were. If it's a human form, you can recognize it needs to be documented.
And obviously,
is that fair?
I mean, this is, without getting into the whole controversial subject of, well, when's a human, when's life, then we get the whole A word. We'll stay clear.
Time we probably transport those babies. Yes.
Yeah, I mean, some of those, I don't think anybody can give you a good, clear answer. You could even argue on that case, was that baby born a week ago there, and they just left it, and now a week later their skin and stuff softened because they allowed it to drown. Sickening to think that, but theoretically, that could have happened. But we document best we can, and we're not going to be 100% on some of those type things.
Any other questions?
Not this time.